Right. Thank you. Brady, you made it.
Ooh,
We didn't
I'm
think Brady was
here.
going to get there. He's there. Thanks.
Thanks for having
Thanks
me,
for
guys.
joining us. Yeah. Well, thanks, sponsors. Again, number 40. If you guys didn't hear when we first started, this is our 40th. Wow. That just
wow,
seems crazy, doesn't it?
it
So,
does.
yeah, it's awesome. Um, we have multiple guests today. Let's introduce them. Let's start with Dan. Dan, you want to introduce yourself?
Here, my name's Dan Prohaska. I work with Rob. I'm in practice in Wichita, Kansas. I have a practice of sports medicine and was able to take care of Rob's son. So that's why I'm getting to be part of this panel that this I think is our final episode and some good updates, I hope.
Well, we may have to bring you back for one more since we
Mm,
since we
mm,
since we had our little hiccup here. We may
Yeah.
try to bring you back for one more. Barb, do you want to introduce yourself real quick?
Sure. Hi, I'm Barb Hoogenboom. I'm the editor-in-chief of IJSPT. And I hail from Michigan, but I happen to be in Carbondale, Colorado right now at my son's house because I retired about a month ago from academia, not from everything else, but yes. So we're
Not from
super
the
glad
Journal
everybody's
Club.
here.
Not
Welcome
from the
to Journal
Journal
Club.
Club. Yeah. Awesome. Philly?
Happy 40th anniversary, everybody. Gosh, I can't believe that. Phil Page from Baton Rouge, Louisiana, professor at Franciscan University. Shout out to my students who are here. And thanks, of course, to the Journal and to Ashley for pulling this off. And, of course, to all of our sponsors. Good to be here.
Hey, if we're giving shout outs, I got to give a shout out to the General. I saw he was
The
on the
General. That's right.
the
Saw him
General
too.
constantly on the Journal
Always
Club. Thanks,
here.
General.
Yeah.
All right. Who else? Brady, introduce yourself real quick, buddy.
Yeah, Brady Soley. I practice in Minneapolis, Minnesota. I do a lot of our ACL reconstruction and rehabilitation up here in Minnesota. So thanks for having me.
No, you're welcome. Thanks for joining us. And then I guess our last but not least guest, Ty. You want to introduce yourself?
Hi, I'm Tyler Manske.
I'm
I'm
camera
Rob's
shy.
son.
I'm camera shy.
I'm Rob's son. I'm here because I tore my ACL.
He sounds like he's at an AA meeting or something. Hi, I'm Tyler, and I'm here because I tore my ACL. Good. All right. Thanks, Ty. So we are. This is our third installment of bringing Tyler and Dr. Prohaska. We were going to do three. We may end up doing another one because we were wanting to do a final one that was kind of like a return to sport, return to play. We really start hitting more activities. But if you've been following along with this, we've had Ty had a little hiccup going through this whole rehab process, and that's what we're going to talk about today. Loss of motion, and I guess before we start, I asked Tyler if he could just kind of explain to everybody kind of what history he's had with this after his surgery, and not you don't have to belabor it, but just give him kind of a quick down and dirty of what was going on after your surgery, how long it kind of took, what problems you were seeing, and then the second surgery that you had, and what's gone on since then.
Okay, so I got my surgery. I tore my ACL like late September of last year, and then we had surgery like late October. And after that, the first couple months like went fine, and we noticed I was a little tight, like in my like hamstrings and knee, like getting full extension. But we figured it was something that would get like straightened out just over time and as swelling went down. And so we went about 7 or 8 months just like thinking it was just going to get straightened out eventually. And it didn't. So we tried a Dynasplint to wear just like around the house and while I was sleeping to help hopefully pull my knee back and like keep me straight, and just like the more pressure that was there pushing me straight would hopefully keep me straight. And so we did that for like 2 months until my like 9 month mark. And it did get better by like a couple degrees. Like it was definitely better than it was, but it just wasn't, it was still missing like, what would you say, Dad? Like 5?
Yeah, probably. He'd
5.
come in cold. We'd usually get we'd usually get his extension maybe all but a couple degrees back. We couldn't get the last little bit of hyperextension that he had, and it would always spring back pretty easy. We couldn't ever really keep it fully extended. And so just constantly struggling with that. And again, we thought early on that it would just in time it would come, right? I mean, some people are a little bit stiffer than others, and as time goes on, they regain that range of motion. But his didn't ever come back. So we had the second surgery, and then what's happened after that time?
So we had the second surgery about a month and a half ago. It was just a scar tissue removal. And since then, my knees just felt a lot better. I like feel less stiff. Like it used to be, my knee would lock up just sitting in the car driving somewhere. Like I would get out of my truck for school and my knee would be locked up and I'd have to stretch so I could even like walk anywhere. But after the surgery, it it just felt completely different. My like extension definitely got a lot better. I come in now and we stretch for like 5 minutes before we get into the actual work of stuff. The hardest part was definitely probably just like the first couple days after the second surgery, just like being all swollen again. And I had a huge,
Yeah,
huge fluid bubble that just like popped out the side of my leg. But other than that, like ever since the surgery, I felt a lot better.
Yeah, able to fire your quad a lot better. Everything's
Yeah.
going way better. So Dan, can you tell I'm assuming it's okay with Ty if you tell everybody what you found when you did the second surgery? Can you just describe
Yeah.
what you saw and what you did?
So one of the things when I go into a surgery like this is I really want to get a good exam when they're asleep. Ty was never really tight from like apprehension or guarding, I didn't think. But sometimes, patients can fool you. So it's really nice to have that anesthetic feel that you know that what you see is what you got as far as your soft tissue envelope. And when he was asleep, his graft feels amazing. It feels perfect, but he did lack his extension, just like he did for Rob. And I looked at his patella mobility and it was terrible. I mean, he was really locked in. Medial lateral glide, even superior and inferior glide was significantly decreased. And that was something that was really impressive as far as, just how tight he had gotten, because I don't recall him being that tight early on. It was just one of those things that was like a slow grind that just kept coming on. And as hard as we worked to get it back, it wasn't moving. So when I actually went in with the arthroscope, when I made my portal, I mean, when you enter that front of the knee and it's full of scar, I mean, you have to use a knife to get through it. It's that thick. And, I think I took some pictures of it. I don't know if you have those to share, Rob or Doll, or not, but
Yeah, I don't have them with me. I mean, I have them, but not where I can show them. But it
the
was thick.
the front of his knee, the scar between normal synovial layer and the fat pad behind it was in some places 3 to 4 millimeters thick, and it laid essentially the entire front of his knee and into the medial and lateral gutter. I mean, it was just socked in. There wasn't anything superior. Far medial and lateral wasn't bad, but that was why his patella just wasn't moving. And I think there was enough soft tissue in the front that was just impinging, and he couldn't get it straight.
And that's where he complained of it hurting
Yeah.
most of the time when we'd work on his extension. And it
Mm-hmm.
wasn't. And then he also had it wasn't like a typical cyclops that you see with like a big blob of scar tissue on the front part of the tibia in front of the ACL, but it was just like a big sheet.
Yeah, it was a whole sheet. Cyclops, I think a lot of times are maybe an under debris. They can form without like a lot of times when we will leave or have left some of the tissue of the native ACL around the footprint of the graft, just thinking we'll get some, Golgi tendon organs or some kind of proprioceptive feedback. And maybe that's old school, but sometimes that happens and you get that prolific scar forming there. His was not like that. I mean, his was truly just a sheet across the entire anterior compartment. And, then you say, well, why did that happen?
Yeah, that's my question.
I've looked at this pretty extensively, and as far as, I don't use thermal devices. I just use mechanical shavers because you think, okay, I did a thermal device. Did I create a burn? Did I create scar tissue from that increased temperature on the soft tissues? I don't use a thermal device. I don't do an aggressive anterior compartment synovectomy when I'm doing the ACL. I just do what I need to so I can clear my space and see. So, this was above and beyond anywhere I touched with the initial surgery. This was a wall across the entire region.
And it wasn't like we weren't, I mean, literally from when we started, we were trying to get his range of motion. We were trying to keep the extension. We were doing patellar mobilization. Every time he'd come in, I've told multiple people, I probably spent more time doing soft tissue, manual therapy, range of motion with him than I've done on anybody that I ever have. And so
Rob
maybe,
told me he was questioning his own credentials quite a bit.
I really was. I really was.
Well, Rob, that's what I was thinking. I mean, how many kids, I mean, plus or minus, Ty, but you can say what you want to say, but how many kids get somebody who's as skilled as their father to work on their knee, who loves them as much as their father? And so that has got to be part of it too. It's like you worked, I'm sure, above and like you said,
Oh,
you
yeah,
gave it
yeah.
your all. You gave it your all. But yeah, even did you foresee this? Or Tyler, did you foresee this fork in the road? Anything that gave you this idea?
Do you want me to go or you, Dad?
Yeah, you can.
I didn't.
Mm-hmm.
Everyone tells me how great he is. And then I'm finally under his care and it goes wrong. So I definitely didn't expect it.
Brutal.
So
I
related
Tyler, don't worry
question.
about Tyler. I'm going to be covering knee mobilizations next semester in Nashville here. Rob, you got an invite to my class. You can come
Because
sit
I've never
in.
done it before. I've never
Yeah,
done
that's
that
right.
before. Tyler
Never
was my
done this
first one.
ever.
Yeah.
Never
Yes,
have I
there.
ever.
I know Phil invites you in also.
So Ty, the other question I had for you is, have you ever had another surgery on your bod, like a orthopedic surgery, that you've had some stiffness with, or have you have anything to compare this to?
I really don't. Like the
Okay.
only other
Not
surgery I've
surgeries,
ever
yeah.
had
Yep.
was my wisdom teeth. And
Mhm.
I
Yep, that
mean,
doesn't count.
that doesn't
So
count.
sometimes
So
that's what I was going to say. Sometimes we'll see, patients who have a history of sort of moderate to severe scarring. So you don't have any history that would give us that, or even, anything that we would say,
Like
gosh, that,
a cut, you don't keloid, you don't create an abundance
no,
of
no.
scar.
Hmm. Okay.
There's a question too in the audience from Tiffany. Was there anything on that? Did you guys get an MRI pre-revision? And was there anything on the MRI to indicate there was a scarring issue, or was the scope more
Oh,
exploratory?
I'm sorry. Pre-revision?
Yeah.
Pre-revision, she's
Pre-revision,
asking? No, we didn't. We didn't because we knew we were going to scope it. So it just seemed kind of.
I like
More.
this question because since I'm unmuted, did you try any other like modalities like shockwave or anything from that standpoint to before?
No, we didn't do that. We did some scraping, stuff, but yeah, no shockwave therapy or anything like that.
And we did a steroid injection too at one point. We were just thought, well, maybe we can get this from, inside, and it helped with your pain, Ty, I think, but it didn't really give us much of an effect on the outcome.
Yeah. So when we finished, I guess we'll get to this article sooner or later, but this is kind of interesting. We did put him immediately after the second surgery. We put him in the Dynasplint, and we had him wear it pretty much all the time, other than when he was in therapy. Pushing him into extension, and not really worrying about flexion too much at that time. And then Dan, what was the grapefruit stuff we had him do? What was that stuff?
Pineapple.
Sorry, pineapple. What is the stuff, Dan?
Was it bromelade? Something
Bromelain?
Bromelain, yeah, bromelain, yeah.
I can go grab it.
It's okay.
Okay.
Yeah, you're okay. So Dan, explain the bromelain.
I can't. I mean, it's just
Oh,
one of
you
those
can't?
things. It's one of those things that's supposed to, reported that it's a natural way to decrease scar
Decrease
formation.
scarring. Yeah. So we got some bromelain, and we had him take that.
I mean, there's some prescription meds that are kind of off label for it, and we talked about that, but we didn't end up doing that either, just because, it is off label, and we didn't want to experiment too much. But
yeah, but since then we haven't had really any problems at all, really. I mean,
it's that
it's been really
bromelain. It
going
fixed everything.
pretty good. Yeah. So I'm gonna get some
I
stock
pulled
in
up
bromelain.
I have the photos pulled up from your surgery, Dan.
Oh, you do?
Yeah, he sent them to my email.
Can you share?
I can share
show
my.
'em on the
How do I
screen?
share my
Leave
screen?
it to the patient.
Yeah.
Down
Yeah,
at
look
the
at
bottom, that
that
green
box
up
says
there
share.
that says share.
Oh, okay.
Be able to use that.
Oh, host disabled attendee screen sharing.
Oh, what
Oh.
a joker. Try this.
Can you
Now
open
try
it?
it.
Yes.
Here it comes.
There we go.
Can you guys see it?
Yeah,
Yep.
you're
Okay.
on. So the
Okay,
medial
so-
compartment was normal. That's the photo 3. And then keep going down, Ty. There's his ACL
Yeah.
graft when we first got in there, and it's well synovialized. There's some scarring
Beautiful.
between it and the PCL, but it looked like a great looking graft. It healed in perfectly. And then lateral, that's page 5. So
Looks
keep
good.
going. And then this is on the anterior, the femoral notch or the femoral trochlea is right in front of you on the right. And the scar that's labeled there was how thick that was going into the notch. So it really was just I got the camera backed up there and I'm looking at it just on the profile there, but you can just see how thick that scar was. That you can see a little bit of the fatty tissue from the fat pad to the left, but it was pretty thick. And then looking up, this is the patella at the bottom of the screen towards the far with that label of scar there. I mean, that's an area where a plica band would kind of be seen, but that just wrapped the entire
huge.
inferior pole of the patella.
And that's thick. That was like thick.
Here's more of it, just looking across the trochlea. And another picture of the ACL and suprapatellar region. I mean, it just stopped up above the patella, which is typical. You know, when I see these, they rarely go all the way up in the suprapatellar tap pouch. And then this is just kind of after the debridement. The cartilage is not showing any, you know, sometimes when you see these things that are really, really tight, it doesn't take long for that cartilage to start getting soft too. So I always worry about that.
Wow.
That's using a biter on the scar. It's just so thick. And there's the medial gutter after I've cleaned it out. And then the lateral. And then anterior. So, you know, I get to the point where my goal is to get to that normal fatty tissue from the patella to the tibia. That's when I do a lysis of adhesions, I'm going to clean it all out. And then his final ACL pick.
Still pretty ACL.
Cleaned all that scar tissue up off of it. You know. All right,
Basically, that was a hugonic space-taking lesion. I mean, it just was taking up space.
Yeah.
Yeah, it was extensive, to say the least. Yeah.
I was going to add in too. You know, it's interesting hearing this story because, you know, like over, you know, at our center we do a lot of these, you know, post-operative MRIs to evaluate, you know, like how extensive scar tissue is and things like that. But to Dan's point, there sometimes like the clinical exam is really probably the biggest clue. Sometimes, you know, like you've ruled out the posterior capsule, you feel like you got some pliability there. It seems to be something maybe pushing back from the front there. You know, you get an MRI of this knee, maybe it looks like, you know, post-operative knee with maybe a little bit of scar tissue up on the fat pad, but, you know, maybe the MRI looks pretty benign too. And then you get in there and you're like, wow, like this substance is not normal and it's actually constricting the function of the knee. So it's pretty cool to talk about.
Yeah. Oh yeah. It's cool to talk about and cool to see when it is debrided and the function come back so well too. I mean, because it wasn't that huge of a loss of motion, but it was really causing a functional loss of ability for him to do things. I mean, he couldn't even walk. I mean, realistically, he couldn't even walk normal.
You know, that's one of the best quotes I've ever heard is that you can take a person without an ACL who can't run and play sports and make them into a person who can't walk if they lack extension.
Yeah.
And so it's one of those things where that's our worst nightmare, right? It's like if you can't get that extension back for normal gait, then, you know, much less running, for heaven's sake. So yeah, it was functionally somewhat disabling for him, obviously.
Yeah. So a couple more questions. Tim Heckman. Hey, Tim, thanks for joining tonight. He asked, was Ty's extension full preoperatively? And I'm assuming he means preoperatively from the original surgery. Dan, it was, wasn't it? When you
Yeah,
did his first surgery,
he didn't have any deficit, you know, and that's the other thing. You look back and like timing to surgery, because one of the articles we will get into, you know, early surgery, a lot of inflammation, that's a risk for inflammation or for arthrofibrosis. He was a month out, his knee was quiet. You know, when I got in there, it was just a quiet knee.
Yeah.
I don't think he had much of an effusion at the time we did his surgery.
No, I think it had gone down pretty well. I mean, he was ready for it. Yeah.
Mm-hmm.
Tiffany is asking, was there any issue with his flexion range of motion pre second surgery or debridement? And I think your flexion was really, maybe it was a little bit off, wasn't it, Ty? But you could bend it pretty good, right? Before the second surgery. It was
my
mainly extension.
flexion wasn't really a problem before.
Can you bend it better now? So sometimes that scar in the front will keep you from bending it comfortably. Does it feel different when you bend it now?
I can bend it more comfortably. Yeah. Like it still isn't all the way. Like I don't have all my flexion back, but it definitely bends more. Like I don't feel it in the front when I
We checked it
bend.
the other day. He was within, you know, as he's doing his heel slide. I didn't measure the actual range, but as he's doing his heel slide, he's, you know, an inch from the other side. So it's pretty close. Question from anonymous attendee. Did you debate use of dry needling for addressing scar tissue? We didn't really think about doing dry needling for scar tissue. We thought about we talked to one of the guys in the clinic about needling his hamstrings because we thought maybe his hamstrings were tight and causing the problem, but it just didn't seem to be like he could, you know, get a straight leg raise. I mean, his hamstrings didn't seem to be the major key problem. It was seemed to be more scar tissue than hamstrings really. So we didn't end up doing it. Like I said, we did some scraping on the front. I think we scraped the hamstrings in the back a little bit once in a while, but we didn't end up doing any dry needling. How far out was he from Morgan here? How far out was he from the ACL surgery when we did the scope? You said it was 9 months, Ty, when you just look back. Is that right?
Yeah, it looked to be about 9 months.
Yeah. And then how far out from, how long has it been from Rajiv? How long has it been since Tyler had his second arthroscopy? And that's been 2 months, you said?
A month and a half.
Month and a half. Okay. So six
weeks.
And then Dan, I guess this maybe is a question for you. What's the likelihood of his scar tissue returning or recurring after arthroscopy?
Well, anytime you do surgery, you can have scar tissue. And, you know, my experience with these is when you go to debride them, there are a few that will have a second scar event, but most of them, that whatever that stimulus was that created the scar, and maybe that's the amount of soft tissue, you know, disruption you did during the surgery. Maybe there's some, you know, factors that we don't quite understand in some people that create this. It doesn't seem to come back after the second one. I mean, it could, but it's just very, very unusual.
Yeah. That's why I've kind of worried about that too with this second one. You know, we weren't expecting it with the first one. So then your concern is that even though you debride it, it could come back. But at least at this point so far, it doesn't seem to come back. And I think as long as we get the motion, you know, like the first one, we couldn't really even get the motion early because of, I think mainly it was because of the swelling in the knee post-surgical and the acute surgery. And this time you didn't have that. So maybe we were able to push it, maybe be a little bit more aggressive with the range of motion to keep it. And maybe that'll keep it away. I hope anyway. Question here, at what point in the postoperative timeline should a PT be concerned about limited end range of motion with extension and have the possibility of it being being tied to scarring? Obviously, in retrospect, I think we should have looked at it sooner than we did. I mean, I wish we would have pulled the trigger and did the arthroscopy sooner now. But as everyone knows, hindsight is 2020, and as you look back, you can say, "Well, we should have done this or we should have done that." But I don't know, Brady. I think when we talked to you before, you guys sometimes will check it really early. I mean, like 6-8 weeks if it's not improving, and start addressing it more aggressive at that point, right?
Yeah, I mean, me and Dr. Larson have a fairly progressive kind of approach to it where, you know, we try to identify in the first 3 to 4 weeks people that are struggling with extension. We do some simple low load, long duration stretching. And if that doesn't seem to be doing things within 10 to 14 days, we're getting splints right away. So I have a knee right now that's 6 weeks out, and he got a Dynasplint today because I was sensing that this is either the capsule or he's got a notch issue going on. And then what we do is we run that for 3 to 4 weeks and just see if it's trending or improving, you know. And then if he goes back to see doc at his 8 to 9 week appointment, and we've already kind of got a 3 week kind of run of what's going on with low load, long duration stretching in a splint, then we'll maybe pull a trigger and just evaluate how extensive the scar tissue is. Now, what I would say with that too is that doesn't mean they're going to get a cleanup. The MRI is kind of to rule out the big nasty things. You know, for example, if you get an MRI at 9 to 10 weeks and you have a substantial amount of, you know, notch scarring or anterior interval scarring, then to me, you know, it correlates things that up, and maybe you're a little bit more progressive with doing a LOA on that procedure versus maybe the next case like Tyler's, maybe that's a little bit more subtle and things like that. You need more time, and you kind of run those cases a little bit longer. And again, that's not saying that's the best evidence for doing that. That's just something that we've started to do to try to intervene a little bit quicker.
The easy ones are the ones that are really tight. Because,
Yeah,
you know, if
yeah.
you see 10-degree loss at 3 months, I'm talking to them about going in. But, you know, when you've got a 5-degree and it comes back when you stretch, you're like, it's going to come back. You know,
Yeah.
that's kind of what I think Rob and, you know, our mindset was like, this is eventually going to stretch out and it's going to be fine. And
Because it
until we
usually
get,
does. I mean, it usually does.
Yeah.
So
Yeah.
it was
But
a struggle.
I think that's what's so unique about, you know, arthrofibrosis in general is, you know, it's a continuum. You can have people that have very little to no scar tissue, and then a bunch of gray area cases where it's maybe there, but it's not clinically significant at 6 months. And the next case does something different, and they're still battling with what looks to be the same amount of scar tissue at 6 months, you know?
agree.
Yeah, 100%. All right. Do you guys think we should get to the actual, this is the journal club, for God's sake, and we haven't even talked about our journal articles. We should probably at least hit one article, right?
Yes.
You guys agree? Okay, so let's go with our first article by Worsham. Subsequent surgery for loss of motion after ACL reconstruction does not influence function at 2 years, which is, I think, a good sign for all of us here on the Journal Club tonight, and especially Tyler. The purpose of the study was to compare clinical outcomes at release to play at 2 years between patients who underwent surgical management for loss of motion after ACL reconstruction and age-matched controls with no loss of motion after ACL reconstruction. Right? Their hypothesis was that patients undergoing a secondary surgical procedure for loss of motion after ACL would exhibit decreased function, delayed time of release to play, and lower patient-reported outcome measures when we compare them to age-matched controls. The return-to-play outcomes that they used, really some of these were more like functional tests, single-leg squat distance, the LESS, single-leg hop test, 6-meter time hop test, 5-10-5 pro agility test, and then they also looked at isokinetic peak torque. I guess my first question is that's quite a bit they looked at. This really I think for the most part I think is a pretty good study. It was done by the Walt Lowe and some of his therapists, which include a good friend of ours, Lane Bailey, helped out with this study. Is there other stuff you guys think that would be important to look at in this kind of a study? Are there other return to play stuff you'd want to see? Anyone?
I was just gonna say, you know, we do a lot of isometric strength testing at our center. You know, we do like a 90-degree isometric. I think with some of these arthrofibrosis cases, it's super important to do what they did, where they tested at 60 and maybe a little bit quicker, because sometimes you don't pick up on the torque asymmetries with an isometric or a slower velocity test. And then when you start cycling that joint a little bit quicker, that's when you start to really pick up the asymmetry indexes. So I actually like to see that they used isokinetic tests to kind of quantify their strength.
Yeah, no, I agree. Dan, is there anything else you want to see from a surgical standpoint, and like what we would typically test them at, or do you think what they looked at was plenty? And
From my perspective, I thought they hit it pretty well.
Yeah, they have. There's a lot of things they looked at. It looks at a lot of different qualities, and probably for the most part, I think it would be plenty. The other thing I wanted to ask Dan about, I guess, and Brady, anyone really is welcome to add to this. This study were all bone patellar tendon bone ACL reconstruction, so there were no other graft sources, no quad tendon, no hamstring tendon, no allografts, things like that. Do you know, Dan, are there differing rates of arthrofibrosis with different graft sources? So if you use a quad tendon, are you more likely to have? I thought I read something recently that potentially, because the size of the quad tendon graft, some people say you may have a risk for having loss of motion.
I think I can't cite it either. I think that there is some thought about that. Any of the anterior grafts, the patellar tendon or the quad tendon, I think you probably are similar risk. It happens in hamstring tendons. I've seen it. I think it's probably least likely to happen in an allograft just because you don't have that big of reaction, probably from the soft tissue response to the surgical insult of the trauma you created.
Yeah. Well, so in their study, they had rates of loss of motions high from anywhere from 4 to 38%. And I guess one thing I guess I wanted to point out is, it's okay. So it's only 4, or maybe 4 when it sounds cool when it's only 4, but when it's your knee, the 4% doesn't matter. You know what I mean? When it's your patient, it doesn't matter that it's 4 because your one that you're seeing right there is 100%. So it's still that percentage doesn't really come into play always. They said the loss of extension appeared to be a larger problem than loss of flexion, and obviously a little bit harder to treat conservatively, which obviously we saw in this case, and I think we see most often. Brady, is it very often that you see someone that has problems where they have their main problem is loss of flexion, and they need to get debridement from it? It's almost always extension, isn't it?
Brady, you're
Maybe muted. Yeah.
Thank you. I think when you start to see those combined flexion and extension losses, that's where I think the clinical progression goes a little bit more towards that arthrofibrosis from maybe like an autoimmune or a genetic component. For instance, like I've had a couple over the years that kind of have flexion extension issues, and their joints react differently. They get that kind of milky pitting edema. The quad shuts down, the patellofemoral joint locks up. It almost seems like there's a Milu type issue going on in that knee, versus like maybe like Tyler, that's an isolated extension issue on that spectrum. Maybe he didn't have as much of an autoimmune component to the surgery as maybe the next person that's dealing with a true like flexion extension arthrofibrosis. The other thing that pops up is just meniscal work in general. Like for instance, in my hands, like our lateral root repairs. When you have a surgeon that's really tacking down the lateral root, I think just the way the lateral meniscus glides, you can end up with getting kind of some capturing and kind of pinching in that posterior lateral corner. And sometimes meniscal pathology, meniscal work, or other procedures done on the knee can exacerbate some of that flexion loss. So there might be an interaction where if you have a big injury, a big subluxation where you got both meniscuses knocked out and maybe some other soft tissue trauma, that might set the knee up for getting a little bit stiffer with flexion too.
I would echo that. I think that the meniscus repairs, especially the ones that, if you're all inside and you're putting something on the posterior capsule and then you tack that meniscus to the capsule, they do have a little bit slower return of their flexion. But I don't think that in itself is a true arthrofibrosis. I think that's more of a isolated, you created that stiffness because you repaired the meniscus. Now, if it goes beyond that and you create a true scarring through that posterior capsule, it's a different animal.
Mm-hmm. And to Dan's point on that too, like I think those cases that have that meniscal work, you let them ride a little bit longer.
Absolutely.
You're not as aggressive with passive stretching. You don't chase that 135 forward. You just kind of let that tissue heal and try to kind of convince it to bend a little bit more over a biological healing time.
I think
For
that's
sure.
right. For sure. I agree 100%. I'm getting word from the IJSPT home office directing me that we should probably go back to some questions. There seem to be some really good questions on the question and answer. So hopefully you guys won't mind. We'll go back to the questions. How often, oh, well, Dan, this is for you. How often, from Raphael, how often do you prescribe bromelain, and should it be done more often?
Well,
I prescribed it once.
recommended it once. And it's funny how this all came about, because my sister's kind of a naturopath, and I had a shoulder surgery last summer, my own rotator cuff, and I was telling Rob, well, I took that. I don't have any idea if it made a difference. And he goes, what is it? And I'm like, well, it's bromelain. And he looked it up, and that's how that came about.
Do you remember the dosage, Tyler? Do you remember the dosage? It's just one pill, right? You take one, was it one a day?
Yeah, just one pill a day.
I don't remember what the bottle says, like how many milligrams or
I'm
whatever
just
it is.
looking on Google, and it says 500 milligrams for, like, if you just buy it on Amazon. So
Or you
Each
can
pill
just,
is
knows?
500.
or you can just eat a half a cup of fresh pineapple every day.
Yeah,
fresh
That covers it.
pineapple, or drink a bunch of pineapple juice. Yep.
yeah. So it was something worked. Maybe it was the bromelain. Maybe it was the combination of bromelain, the Dynasplint. Maybe it's bromelain Dynasplint combo and debridement, all of it. I've seen Rajiv again. I've seen a similar clinical finding on a patient who had a meniscus repair, you guys talked about, and arthroscopy for DJD in her knee. Have you seen this with other arthroscopies? Dan, you don't typically see motion loss problem like this for just general arthroscopy issues, do you?
Can't think of a time where I've seen an arthrofibrosis without some kind of reconstruction. You know, it's not from meniscus, it's not from condyle work, it's always a ligament in my experience that I can recall.
Yeah. I'm going to butcher this name, so I'm going to apologize ahead of time. Shoban Babu Komu. What is the reason for developing huge scar tissue in the knee? Thank you, Shoban Babu. He or she's asking poor rehab or idiopathic.
I think she hit the nail right on the head.
Obviously poor rehab. Yeah.
She hit
Next
the nail on the
question.
head.
Next question.
Now I do think we need to go back. Besides poor rehab, it can be poor surgeon. It can be poor surgeon because if you put the graft in the wrong place, you're never going to get extension, or you might not get flexion. So you have to have a surgeon that's put the graft in the right spot, because you will never get extension if the graft is too anterior, if you've got the graft in the wrong position.
Yeah, that's a great point. That wasn't what we saw in this case, and I've only seen that maybe a couple times in my 31-year career where someone's done poor placement of graft, but it still does happen. I mean,
I see grafts I revised
yeah.
that especially the very vertical grafts, that's more of an issue of why did they fail, but the graft placement is still an issue. We all have to get better.
Yeah. All right, Gene Pearl Jones, did his motion always lack similarly, or were you able to get more motion early on, then saw that it start to move backwards? And yes, it was a quad tendon graft. And I would say that his motion was pretty, we gained some motion because early on he didn't have very good motion. I mean, he's like a typical ACL patient. The first maybe week, there was a lot of swelling and he didn't have full range of motion because of the swelling. But as the swelling started going down, he gained motion. But after a certain point, it just kind of got stuck at that, several degrees loss that we could get passively. But he couldn't get it actively. And so I think part of the thinking too was his quad wasn't firing good. And when the swelling would go down, his quad would fire better and be able to extend it, past that little bit of stiffness that he had, but we couldn't ever get it comfortably past the stiffness, and therefore he couldn't fire his quad he could fire his quad some, but he wasn't getting a really good contraction of it. Like now he fires it and you can see it fire. It's firing way better, and his knee's fully extended. And, like you said, literally we were working on his motion for probably 30 minutes or more, and now we work on it for 5 and it's full. So it's totally different after the debridement.
This was a question related to that down the line a little bit from Taylor Sullivan.
Okay.
From Gretchen Caulfield. Was his patellar motion always limited?
No, I don't think. Well, No, I mean, it was limited a little bit early again because of the swelling.
Yeah.
But it started getting better, but then it started getting stiff and less mobile as time went on, just kind of like the rest of his knee did too. Yeah. Yeah. Evan Burchard, any use of laser therapy? No, we didn't have we don't have we don't have laser therapy in our clinic to use. So, and to be honest, I didn't think of using laser therapy for it. So no, we did not use that. What is the reason to develop the arthrofibrosis? Is it aggressive rehab or is it idiopathic in nature? That's a good question. Dan, can you, I mean, the scar tissue as you saw it in his knee, is that something that you would get from doing aggressive rehab?
No,
It seems
I
to be
don't,
more,
I don't
yeah.
think, it's not like an adhesive capsulitis where you push it harder and harder and it can get angrier and angrier, but maybe, um, in this
His knee wasn't
situation,
ever really, his knee was never really angry. I mean, it
no,
wasn't ever really just like hurting all the time and inflamed or anything. We just couldn't get it extended
right. I
or
mean, I
flexed.
think there's an answer to why this happens, and I don't think we've really even talked about it tonight. I don't know what the answer is. I mean, is there some kind of unidentified, even an infection that, created some kind of environment that created the need to create this fibroblastic response? Something created the response that the knee over responded with fiber, with scar.
Scar tissue, yeah, yeah. Just like, yeah, like a systemic problem or a systemic something that got triggered for some reason. Raphael, how many months after surgery did you decide to go and do um, the manipulation, or not manipulation, but the debridement? How frequent was therapy post manipulation? You said it was 9 months, Ty, right? And then we did therapy like every two to three, or typically 2 days a week, wasn't it? Yeah. And 9 months, was I right? 9 months, we said earlier. Yeah.
I would assume he's doing stuff on his own at home though too.
Yeah, at home, and he's going to the gym on the days that he doesn't come to rehab. Yeah. Yeah. I had something I was going to say, and I've just totally lost it. You ever do that, Ashley? Just lose it? It's just like it's right there, and you were going to say it, and then
Yeah.
All the time.
yeah, okay. Taylor, is that
indications of Taylor Sullivan asks, what are the indications of a scope versus manipulation under anesthesia?
I don't really like to do just manipulations simply because of the fact when you take somebody and they're under anesthetic and you stretch them, you might get the motion, but you didn't fix the problem. You have to look in with the scope and look at the soft tissues because you'll regret the day you didn't do the scope.
Yeah, I really wish we'd have done this. We talked about it before you and I did. We probably should have did it sooner, than just.
Well, when we were talking about the Dynasplint, that was probably, we should have been talking about the Dynasplint 3 months before we talked about it. And when we were talking about the Dynasplint, we probably should have been moving to the scope.
Everyone was just really convinced that Rob was such a great therapist that he should be able to fix this. So
Yeah.
I have a question though. Just is there any use of, and this could be anyone, or Brady, maybe you guys have looked into this, but any use of the like in-office scope options in a situation like this, like the My Eye or some of these other things that are out there, to be able to visualize what's going on in there and then say like, oh shoot, we might need to actually go in and do something?
Yeah, you guys don't use any of that, Dan. So
The issue with that is it's a very small cannula. And if you could get in and see, you would see that there's some scar tissue there, but I don't think you can really manipulate it and you can't really feel how much there's there. And if it's really as stiff as Ty's was in the front, you would get the scope in and you wouldn't be able to move it around. You couldn't even visualize the rest of the knee because it would be stuck in that scar wall that that I showed I'm taking out. So you would have an incomplete exam. So I don't, there's a lot of reasons we can't use that in the office very well. But in this situation, I wouldn't even consider it if I had it available.
Gotcha.
Tiffany is like got all kinds of questions she's asking tonight. Way to go, Tiffany. would really slow strength progress with end range minor deficits indicate scar tissue issues? And how does arthrofibrosis affect biodex testing? Brady, you want to take that? You want me to try to take it? Do you feel comfortable with that?
I missed the first part of that question. It was
she's asking, would really slow strength progress with end range minor deficits indicate scar tissue? So with that, I think what she's asking, would the presentation of someone who's not getting their, I think that's what she's saying, would someone with.
She clarified then with the follow-up question. She said, in other words, would you expect someone's strength to resolve over time, even if they had arthrofibrosis, or would strength not return due to the mechanical issues?
I think they would have a hard time getting their strength back due to the mechanical issues, but Brady, you can.
Yeah. I was gonna say, I think it goes back to what we talked about with Dan, is like, I think it's on a continuum where you have some people's nervous systems, bodies, whatever, that they can build strength through it a little bit, and they find a way to kind of pull through the shag rug, if you will. And the next person, that sensory experience of trying to fire into that just causes a ton of AMI. And you strengthen. I always use the example, it's like you're trying to try to fill up the bathtub without putting the cork in it. Like, you can strengthen that quad all day long, but if the sensory environment's whacked up, the nervous system's not going to like it. It's not going to hold water.
Yep. Tim Heckman, again, another good question. Are there any other devices you would consider other than the Dynasplint? So, for example, the ERMI extensionator and or the JAS device.
JAS.
JAS, yeah. I haven't had experience with any of those. So the only thing I've had the experience with is a Dynasplint. Brady, Dan, anybody else?
They're all versions of the same.
Yeah. I mean, what I was going to say is, first off, foremost, I have no affiliation with Dynasplint. I've just tried devices, and in my hands, I like the Dynasplint's ability to kind of subtly adjust. I think the ergonomics for sleeping is a little bit more natural. Some of the devices kind of get big, kind of robotic, kind of exo frames on them. Dynasplint's a little bit lower profile. So in my hands, I just feel like I get better compliance with the Dynasplint, and I like the ability where my patients can bring it into the clinic. I can use my own screwdriver and fine tune the resistance on there, find the sweet spot, because really what I want is something that I feel like is going to help stretch, but they're going to be able to wear for 6 to 8 hours. You know, if the splint's too tight and they're saying, hey, I have to take it off after 2 hours, it's not going to do as good of a job as if it was on for 6 to 8. So we got to be able to adjust them in clinic. And the Dynasplint's just a device that I find is really kind of clinician friendly.
Yeah, Tyler, can you explain how that felt when you got it? Because I know early when we first got it for you, we turned it up and it was a little bit too strong to be able to tolerate it for really a long amount of time. So you had to kind of play with it.
Yeah. So the first day we got the Dynasplint, we put it on and we started at 6, I think.
It goes to 14, right?
It went to 14. And at first it didn't, like, it felt like it was pulling a little bit, but I figured I could put it on higher. So I just like cranked it up to like 10. And then after like 10, 15 minutes of it at 10, my knee was just like hurting and sore. And so we took the approach that the manual did tell us not to do that. So we turned it back down to where I felt like a little bit of a tug, but not enough to where I was like in pain. And just every couple days we would turn it up a little bit more and just like gradually.
Yeah, eventually you got to where you could take it pretty much the whole way though, right?
Yeah.
And I was going to say, Tyler, I think that's a little clinical pearl you just said in yourself there. Like Dan brought up, like, you know, what things are causal and maybe exacerbate this scarring and stuff. I do believe if you're too aggressive pinching down on an anterior interval scar, there's a potential that you're going to cause a reactive inflammatory process, and that might actually facilitate some of that kind of synovitis or whatever you want to call it, kicking up again. So I think when you use the splints, it should be, you know, a tension that you feel is helpful in doing something that's not spilling over into a, you know, a pain or a reactive effusion when it's on.
Can I ask Brady and Rob real quick? Those numbers, are those numbers arbitrary? I remember reading somewhere, can't quote it, but like 8 ounces is kind of a target to start with, 8 ounces worth of pressure. I don't know. I'm just trying to figure out if that's 6,
Yeah,
8,
I'm not
10.
sure. Do you know, Brady, if is there a certain amount of
Yeah,
force per number?
I don't know what the weight is, but what I'd say about that, Barb, is like, you talk to the Dynasplint reps, and again,
Mhm.
God bless them because they're super helpful people, but they'll run this protocol, right? And what
Mhm.
I found with the protocol is sometimes the protocol requires 2 to 3 weeks of them turning it up to even feel anything. And in
Okay.
my hands, I'm like, well, I just kind of wasted a
2 to
little
3
bit of
weeks.
time trying to figure this
Mhm.
out. So I'm a big believer in, like, if I see my ACL twice a week, perfect, scenario, I adjust
Mhm.
it on Tuesday and I see him again on Thursday, I'm getting feedback right away whether I can
Mhm.
go up or down with it, to try to
Mhm.
cut down on that time frame of it just sitting there
Sure.
doing
Sure.
nothing, because I do think that sometimes happens with splints, is patients will put them on and they're just not, the protocol's not progressive enough for them to find their stretch right away, and then therefore you're coming to the conclusion that it's not really doing anything, but really what you need to do is maybe
Mhm.
Turn it up a
optimize
bit,
that
yeah.
setting a little bit more.
Sure. Sure. And I imagine it's very individual, in terms of
Yeah, totally.
whether the research says 8 ounces and 6 ounces feels like a massive stretch. It doesn't really matter. Yeah.
I was gonna say, Deb, or Barb, case in point, this knee that I'm getting the Dynasplint for, this gentleman's like 285 pounds.
Oh,
You know what I mean?
yeah.
So like a 6 on him is not gonna even hold his
Almost
ligament.
nothing.
You know
Yeah.
what I mean? Like,
Yeah.
Mhm.
this is a guy that's
Yep.
probably gonna start at 11. I don't know.
Yeah, close
Mhm.
to the
Yeah.
close to the end of this
Can you
guy.
see
Yeah.
this picture? Can you see this picture I'm holding up?
Now we
It's-
can, yeah.
Yeah, it's the 3 x 10 = 0 brace, and Freddie Fu used to love this. Of course, that's 20 years ago, but he'd walk around in clinic and he'd say, "Get them 3 x 10 = 0 brace." The concept of that brace is much simpler. It's basically the patient tightens down the strap above and below the knee for 10 minutes 3 times a day. And we used a number of those and they did help, but it's not nearly the amount of dynamic ability you get from the Dynasplint. But in a situation where if your insurance won't cover the Dynasplint because it is a daily, I believe, or weekly rental, that may be another option for people if
Mhm.
they can't get that covered.
Yep.
Tyler, I'm
And
gonna
Ty, how is it sleeping in it? I want to know. Honest, be honest. To sleep in that big old thing.
Horrible. I do not
Thank you. I thought
recommend it.
so.
Well, what I was gonna say is I might throw Tyler under the bus a little bit, but the other reason I like the Dynasplint is actually for adjusting it for sleeping, because with some of my young people, compliance during the day, getting them to do a low load, long duration throughout the day, I just don't know if my compliance is as good during waking hours as it is when I can get them to shut down for a few hours at a time.
Yeah, Ty did it pretty good. He actually wore it like he was supposed to. Believe it or not, he was fairly compliant with the Dynasplint.
This
So
is since we're getting close to time already, which is wild. I just want to call out, we actually have one of the authors of the paper we're discussing on tonight who had
who's on?
Jackie, and I'm going to mess up her last name, I'm sure. Clahig.
Oh,
She said, in our study at the time, the article we're reviewing, we were not using internal bracing. Have any of you noticed that internal bracing causes increased stiffness and loss of motion? So, and just shout out Jackie. Thanks for being on
yeah.
for your
Jackie, thanks for
paper.
joining. Yeah, thank you. That's awesome. Dan, can you want to answer that one?
I don't use internal bracing. I know that it's around, but I haven't not found the place for it for me yet.
Brady, anyone up north use it?
Yeah, they're using it, and I've seen a few cases of it, and again, like, I probably don't have a high enough end to say for sure what I'm seeing, but I do think there's something provocative about putting intra-articular synthetic material. I mean, we've been through it with the Gore-Tex grafts back in the day, and I do worry about having extra material in the joint and that causing reactivity of the knee.
Yeah, good. Do we got 3 minutes. Do you want to start the case in point or keep going with questions?
I got one I
think?
want to ask Tyler.
Okay.
And this is the mom in me. Sorry, Ty. Um, how frustrating was this for you, or what are your thoughts? Like, what are you thinking about like this in the future? And the future's looking bright now, but along the way, you've had some hiccups, right? Just give us a little patient vibe on this.
I mean, setbacks, I mean, they happen
Yep.
to people all the time, but it definitely wasn't like anything like mentally, I think I've been there for the
Mm-hmm.
most part, like being okay with it and getting through it. Like every once in a while, I'd have a moment where it's like, "Ugh, I just want to be done and I want to
Mm-hmm.
give up and I don't want to go see my dad every Tuesday and Thursday at 5 o'clock." But I mean, like second surgery, I won't at like being that far and not being healthy, I wanted
Mm-hmm.
to do it
Mm-hmm.
just because I'm like ready for things to be back to normal.
For sure.
But I mean, other than that, I've been pretty good. I haven't had too
Thank you.
much struggle with it.
Thanks. I appreciate it. I mean, I know that we all struggle with our patients. If this happens and this happens along the way, it happens to all of us. And for whatever reason, sometimes we don't know, but I know it is a struggle for the patient. So thanks for chiming in.
All right, we can go to the case in point.
Sure. Want me to go ahead and introduce?
Yeah, so just for anyone that's new maybe or didn't catch the beginning, Barb's going to do introduction of our guest here, but again, ATI and IMISCA have been huge supporters of the journal, and so this is kind of a little added segment. We hope you stick around for it. It won't be more than 10 to 15 minutes, but just a little additional segment. We'll let Barb introduce our guest here with an ATI resident.
Awesome. Yeah. So again, this feature is sponsored by ATI and AMISCA. Tonight we welcome Alexis or Lexie Giusti, and she's a ATI sports resident who's currently in Arizona. And when I asked her, I think she graduates next week. So she's ready to go. And Lexie, if you can go ahead and share your slides or share your screen, that would be awesome. And we welcome you, and we're thankful that you came to Journal Club to discuss the case in point.
Yes, I think I need to, hold on.
Looking good.
If this works. Okay. Oh,
Presenter view
glad
and
we're
you're
on the
ready to
second
go.
page. Okay.
Yeah.
So a lot of the topics that you guys
Go to
went
full
over,
screen. Oh, there you go. Perfect. Thank you.
is it good? Okay. So a lot of the stuff that you guys had discussed earlier about kind of the experience of an arthrofibrosis is very similar to what my patient went through. She actually had another issue with her range of motion. So we're going to kind of go through how her plan of care went. Just for reference, she started getting treated at the clinic before I arrived. I came into her treatment around the 5-month mark of post-op recovery. So a lot of this beginning information is stuff that I've gathered after we've collaborated and talked with the other PTs that had treated her. I had a 16-year-old female patient who tore her ACL during a volleyball match. She also had a medial meniscus tear. It was non-contact. She had some history of left knee discomfort that she'd been complaining of prior to this accident. She also had bilateral flat feet, which definitely got a little bit worse with this limited range of motion. Her swelling and pain was really bad. So when she came in for her first appointment, it was 4 weeks after her injury, and she was in PT for 3 weeks before she went off and had her reconstruction. So her first initial eval, she was lacking 26 degrees of extension, and she only measured 56 degrees of flexion. So wasn't great. And by the time she left for surgery, she was at 5 degrees lacking and only 96 degrees of flexion. After her surgery, she came back, and her initial eval, they couldn't do any measurements because she had so much pain guarding. She reported a 10 out of 10, which, as we know, as PTs is not our favorite answer. And we measured her at lacking 14 degrees, and then she went only 84 degrees of flexion, which is technically worse, which wasn't great. And that was 3 weeks after her surgery. So as we go through her recovery, as you do with any ACL patient, obviously she's in a lot of pain. It's more pain management, swelling, just trying to get her to get some increase in range of motion. We started to notice that as the doctor released her to do toe touch weight bearing, this is also the protocol that the doctor gave me for her recovery. Toe touch weight bearing, and then she progressed at 4 weeks to the 50%, and then they cleared her for full weight bearing at 6 weeks. Obviously, around that mark, we're trying to reach that 120 degrees of flexion. She only got to about 118. So we thought, okay, this isn't good. The doctors got a little bit concerned. And so they tried to work on her flexion and her extension and really wasn't getting much of a change. She actually went back for a manipulation. She was 8 weeks post-op and she had her manipulation. And this next slide kind of just shows her range of motion progress, I guess you could say. So after her manipulation, she only had 8 degrees lacking of extension and 96 of flexion. So again, she just got her knee yanked and still we're not getting much out of it. At 12 weeks, her doctor said she wasn't concerned. And at 16 weeks, the doctor had told her she's cleared to start jogging. From the sports residency standpoint, we know that there's some certain guidelines that we want to have in regards to when they're good to run. And that's going to be, you know, is their strength somewhat symmetrical? Is it at least 70%? We can start some jogging. And then also in the fact that the knee range of motion, her other knee, her right knee, was 150 degrees of flexion and she had -2 of extension. So that's a big difference between the two legs. And her course of treatment was 33 weeks. And after I'd started working with her, we went through a lot of different options of what we could do. So as far as those go, we did cupping, stem, we did the scraping, we did BFR. When I started with her, I saw her doing like athletic agility stuff. She was jumping, kind of doing hops and stuff like that. If you looked at her, her knee looked like a knee flexion contracture. She dipped into valgus very off. So I thought, let's do BFR. Let's see if we can get it stronger. And then she also really struggled with that muscle guarding. So you kind of look at, you know, is there a structural block or is there muscles that are preventing her from getting her range of motion? After we did BFR, her strength improved, but still she had a ton of muscle guarding and they had done dry needling to her quad and her hamstring in the past. But I thought, what if we try to address her knee function and muscle function at the dorsal root? What if we can get some sort of sympathetic inhibition with the dry needling to see if we can get any of that muscle to release and let her get more range of motion? On her first treatment with the lumbar dry needling, she got a 10-degree improvement in her knee extension. I think it was 10 or 11 degrees because she came in at 21. She was coming in at 21 degrees lacking of extension, and it improved to about 10 degrees lacking. So we knew we were onto something. So we kind of rolled with that. She would get dry needling on one day, and then the next time she would come in, we would do IFC on her lumbar spine, the sticky pads instead of needling, while she was doing her exercises and getting her mobs. That worked only for a little bit, and then it started to plateau again. And we were like, all right, something doesn't seem right. Like we are trying everything. So what about, let's get back to the basics. So this is one of my favorite quotes that they talk about all the time in the residency is when you hear hooves, you think horses, not zebras. This was a point in time that we thought, so we knew she had continued stiffness. Every time she'd come in between appointments, she'd go right back to her 20 to 18 degrees lacking of extension. We'd improve it down to 6 or 8 degrees lacking. Then she would go home, same thing. She'd stretch. She even wore, we didn't have the Dynasplint. She actually put her knee brace back on and she would wear that around and just see if she could get any improvements. It didn't do too much. She had pain with all of her motion, so that was kind of frustrating. And her gait was obviously abnormal. So we were thinking, all right, what could it be? And naturally, like we automatically think cyclops lesion, of course. Anterior knee pain, limited flexion, sure, but she had pain with all range and the stiffness, everything just wasn't adding up. Didn't really know. So at that point, we thought it might be time to send her back for some more imaging. She went and got some more imaging done, and she had been diagnosed with a ganglion cyst on her ACL, which I was not familiar with, nor was anyone else in the clinic. It didn't seem like we had heard about it a lot. The prevalence of it, any MRI that has been done from a study that they found said that 0.3 to 2.3% have a cyst on their ACL. The causes can be trauma to your ACL, any structure, tendon sheath irritation, so yanking on it, overdoing it. And it often involves a meniscus tear. And lo and behold, she was diagnosed with also a minor but lateral meniscus tear in the MRI. And then the swelling, the pain, the effusion, her swelling wasn't horrible, but it was on and off. And again, her knee was flexed, so it's kind of to be expected. And you can be limited in both ranges of flexion and extension, mostly extension. So for the treatment for that, they recommend either you do rest, you do anti-inflammatories, you can do an aspiration, but it leaves the cyst walls in there. If it can regrow essentially. They can go in there, they can debride it, and they can take it out. If it has done enough damage to the mucoid lining, I want to say it was a mucoid degeneration from the cyst, they'd have to do a full ACL reconstruction all over again. So after we found this finding for the patient, obviously she wasn't very happy. She's 16. She wants to go back to playing volleyball. Her leg does not look the same. She can't do her normal functioning things. Needless to say, she was pretty discouraged and upset. And her mom, obviously, they'd been through a lot with the manipulation. And we referred her out to go get assessed by the doctor. Unfortunately, we have not heard back how she is doing now today. We'd reached out and still hadn't heard back, but it was kind of it's not a good story to tell, but it is an interesting one. So when we look back at the case overall, because obviously a lot of us had been able to treat her over her time, we kind of were just like, this is was it something that we missed? Was it, what about the function of the knee before the surgery? Was it a hot knee? Like, her flexion and extension were not great to begin with. We didn't make a huge improvement, even though I know that in the study it says, is timing from injury to surgery a factor? She had about 7 to 8 weeks between. So we thought, okay, maybe not. And also we were thinking, okay, we have improvements. We are getting a little bit better extension, a little bit better flexion, but the big picture of it, there wasn't too much progress, at least in relation to the other normal leg or unaffected leg. And the healing timelines and the tissue healing times and the timeframes and the goals that we're expected to make with an ACL reconstruction, those are really important, but I think we kind of missed the big picture of how's she doing? Because every time she came in, she's complaining of pain, her stiffness, like obviously her emotions are pretty down, and she's so guarded. Like, she's 16, she had an injury, she had a surgery, and then a manipulation. When I came across her, I was like, you are so guarded that every time I hold your mob, you are just locking up everywhere. So I think there was a few things, like, hindsight 2020, that I think that could have been addressed, but also just an interesting case because it's not something that we see every day. Sorry, I have a cat and he's hyper. He's jumping. Sorry.
Thank you, Lexie. That was very, very interesting. All right, Rob, you want to wrap us up? Or you want me to?
Sorry, do I wrap this up or is Ash? I thought Ashley usually does.
Okay.
I'm just throwing you a curveball. We're gonna start something new at episode 40.
That's right. Then we need Philly to wrap us up.
Phil can do it.
Is Phil still on?
No. Thank you for everyone, all over 200 of you that stuck around all the way to the end. And thank you, Lexie, for joining us. Congratulations on getting through your sports residency. We know how challenging that can be, and best of luck to you. So everyone, we will be back next month, which I believe is already October, which is wild.
Crazy.
So we hope to see you guys there. As usual, just reach out if you have any questions, concerns. Thank you, everyone. Good luck, Ty. Good work. Hopefully your therapist does a better job this go around.
Yeah, I'm going to be sending you some pointers, Tyler.
Yeah, we'll send them some pointers. Everyone have a great night. Thanks, everyone.
Bye, everybody.
Thanks, guys.
Bye.